Hi, good evening, everybody. And this is our last evening, can you believe it, of our 8 weeks of rural onboarding. We've had an extraordinary range of amazing presentations. Remember, they're all uploaded onto the YouTube channel. And we've been putting together resource packs every week that's been updated to help you give all the tools you need to be able to work wherever you are, no matter how rural or resource restrained it is. And we have a very special presentation for our last presentation. We've had to move it, and Julie might or might not mention some of the implications of the recent US aid cuts. But we want to focus specifically on childhood TB. And what is very exciting in the world of TB in general is that we now have a new TB guideline that's been released by the Department of Health, but also a whole range of new technologies and new possibilities that's actually come and has changed everything we think we know about pediatric TB and how we manage it. And this evening, we can speak to somebody who's actually been in the trenches and helping us get these guidelines together and some of the changes that's been happening, but also is going to look practically on what does that mean for you where you are within your rural facility. So Julie's an infectious disease pediatrician who she's currently working as a pediatric TB technical specialist for the Aurum Institute. She's based in Cape Town in South Africa, and she has a variety of national and international HIV/TB implementation projects and some research roles. So she's worked in a variety of government and private institutions in multiple provinces in SA, and as well as 4 international deployments with MSF. Prior to starting at the Aurum Institute, she was leading the pediatric unit at the Brooklyn Chest TB Hospital in Cape Town for 5 years. And her main areas of interest at the moment are clinical care of children with complex pediatric, drug-sensitive or drug-resistant TB, health system optimization to facilitate earlier recognition and intervention, and her priority is making the prevention, diagnosis, and management of childhood TB less intimidating for clinicians at all levels of care, through training, support, and shared care models to decentralise high-quality TB care for children and adolescents. So absolutely perfect talk to help really take our care of children with TB a step forward. I'm going to stop sharing my slide. Julie, and you can then share your slides and take over.
You just confirm that you can see my slides well?
Beautiful, perfect, and it's on the perfect view as well. Well done.
Oh, fantastic. Look at me. I'm just going to say hi quickly so that you can see what I look like. I can't see myself there, but hopefully you can see me. The evening light is not really doing any favors. I'll switch my camera off in a second just to increase the bandwidth for the important stuff. But it's always nice just to say hi to you. I wish I could see all of you, and please come say hello if you see me in any other forums. Thank you very much for a very introduction, and it's such a privilege to be here. The first interaction I had with Rudasa was a few years ago. I was part of your conference, and it really is. I still think it's the best conference I've ever been to ever. And I go to a lot of conferences just because there really is a vibe and a spirit and a feeling of, making things happen. It's not just research that sort of doesn't go anywhere. I think this is a really, really big privilege for me to be presenting to you. As Madeleine mentioned, I'm sorry that this kept getting delayed. One of the main areas that I was working in was under a grant called Accelerate One. That was a USAID grant that unfortunately has now been terminated. So I'm sort of coming to you from a sort of very vague hat, but during the period of the stop order, we had to be very cautious on not disobeying that stop order. But we are where we are now, and I'm hoping that today or this evening, we can have a look at making you feel a little bit more comfortable with something that people generally find really, really scary, and for you to realize that you're never, ever alone in making these decisions, and that we all guess a little bit better if we guess together. So I tried to make this a little bit of a different presentation to usual. I'm not going through epidemiology and stuff. We've got a lot more interesting stuff to talk about. I also don't want to assume that you know a whole lot about TB to begin with. I don't know your settings. I don't know what your areas of interest are. So we're going to cover a couple of different sections. And in each of those sections, I'll cover what's old, so what's just background knowledge that you might need a refresher on, what's new, What's a little bit different in kids? If you're comfortable doing this in adults, why is it harder or easier, or what's different in children? And then what makes it a little bit different in rural? So not all the sections will have a component, but most of those sort of slides will creep up, and you'll see there's a bit of color coding to help us through that. So I think it's always fun to see if you are using your hour well. So let's do a bit of a pre-test, and then hopefully at the end of the chat, you'll feel a lot more confident that you'll get full marks for this. So there are 4 questions, each has 5 points, and I'd like you to give yourself a score out of 20, and then if we have a bit of time at the end, we'll go through these again, and hopefully you'll get 20 out of 20 at that point. So the first question is, if we're comparing children and adults, children are more likely than adults to develop active TB once they are infected. True or false? And more than one can be correct. Children are more likely than adults to die if they are left untreated. Children are more likely than adults to have a positive lab test before they show symptoms. Children are more likely than adults to have a poor response to treatment. Children are more likely than adults to present with extrapulmonary TB. Then if we look at diagnosing TB in children, a urine lamb test is a good option for a child with severe acute malnutrition who cannot produce sputum. Most children with active TB will have a positive NART test on a pulmonary sample. So a NART test is like a gene expert or one of the other similar types of tests, but we now refer to them as NART tests. A chest X-ray change might precede any clinical symptoms in children. TB skin tests are useful at deciding if TB contacts have active TB. A gastric aspirate is the pulmonary sample most likely to yield accurate results in children. Okay, so we'll look at the answers in a moment. So children are more likely than adults to develop active TB once infected. That's true. The kids have a very poor immune system. So basically, if the TB can get hold of them, it really goes crazy compared to adults who are a little bit better exposed, better protected. Children are more likely than adults to die if they are left untreated. That is true. It is because they, again, don't have the immune system to assist with that. Children are more likely than adults to have a positive lab test before they show symptoms. So that's untrue. You really struggle to get positive lab tests for children regardless of what setting you're in compared to adults, and that's just because they have so few bacteria in their airways compared to adults. Children are more likely than adults to have a poor response to treatment. That's false. So children do really, really well. If we can find them and we can get them onto treatment, the success rate is actually better than in adults, and they actually cope really nicely with the medications as well. Children are more likely than adults to present with extrapulmonary TB. That's true, again, because the immune system is just so bad at keeping things under control. So once it's gone in, it can go anywhere it likes. Diagnosing TB in children. A urine lamb test is a good option for a child with SAM who cannot produce sputum. So that is false. There's currently not enough evidence to show that a urine lamb test is useful outside of the very, very narrow group of patients that we know it does work for. Obviously, there's work being done on this all the time, but currently that's not a replacement. So we really strongly recommend that lamb is only used as it's recommended, and watch out for any changes that might come later. Most children with active TB will have a positive NART test on a pulmonary sample. Unfortunately, that's not true. So it's actually a very poor performing test in kids. Chest X-ray changes may precede clinical symptoms. That's true. TB skin tests are useful at deciding if TB contacts have active TB. That's false, because a TB skin test only really tells you that this is a person who's exposed to TB, which you already know if they're coming to you as a contact. It doesn't differentiate between active disease and a TB infection. A gastric aspirate is the pulmonary sample most likely to to yield results in children. That's false. We always prefer a sputum. So in a slightly older child, we're really trying to encourage them to produce sputum or an induced sputum. Induced sputum and gastric aspirate are fairly similar, but a spontaneous sputum sample is always the best option if you can get it from a child. Okay, so the next question. Treating TB in children, it's safer not to start a regimen until drug susceptibility is confirmed. Only children under 5 or people living with HIV need TPT if they are living with a newly diagnosed TB client. Children should always be prescribed dispersible medication if it's available. Children who are living with HIV may need adjustments to their ART regimen while on TB treatment. Children who are living with HIV may have treatment options, may have different treatment options to HIV negative children. And then I've given you a little case study. So I've got a stable 4-year-old child with a strong TB contact history and poor growth for 2 months. And he has a cough and a fever for 2 weeks with bilateral cervical lymph nodes, but cannot produce a pulmonary sample, and no chest X-ray is available at your facility. This child should be started on TPT and a course of antibiotics. This child needs to be started on TB treatment. This child needs an HIV test. Chest X-ray is essential to decision-making in this case, and the child should be referred. Child should be given antibiotics and reviewed in a month. So let's look at the answers there. So firstly, is it safer to start?
Can I just quickly ask, can people just watch out that they don't touch their screens or write on the screens, because everybody can see your ticks. So somebody's using green ticks and somebody's making pieces of, just please don't touch the screens. Unfortunately, we can all see it. I've been clearing the drawings as they've been coming on. But please just, watch out. I don't know how to unset it that your notes are not seen by everybody else. Thank you.
I think you're all magical. I didn't even know that was possible, but anyway, let's move on. Is it safer to start a regimen until drug susceptibility is confirmed? Unfortunately not. So most of the time in kids, we aren't going to know for sure what the drug susceptibility is, and we're going to have to go with a best guess because we can't wait that long. Only kids under 5 or people living with HIV need TPT. That's also false. We're going to go through that in the very first section on why we expanded who needs TPT. Kids should always be prescribed dispersible medication if available. I've said false to that because kids are all different. So sometimes you've got a 3-year-old child who would much rather take a half a tablet than have to drink down this horrible medication. So generally we like dispersibles for kids and it tastes a little bit better, but always be guided by your own patient and don't assume all kids are the same. Children who are living with HIV may need adjustments to their ART. That's absolutely correct. And children who are living with HIV may have different treatment options to HIV negative children. So that's true, particularly with TPT, but usually we're going to try and treat the best that we can, and we'll have to just make the adjustments that we need to make accordingly. So the scenario I gave you, I hope I painted a very clear TB case. I mean, you don't need to be a genius to work out that child's got multiple symptoms. They've got the chronic history and they've got a contact. And what I really wanted to show you in this example is that even without a chest X-ray and without a pulmonary sample, this child should certainly be started on TB treatment. And an HIV test is always a good idea. So we did nothing that could have been done at a referral hospital that you couldn't have done yourself. Okay, so what's old? Firstly, what do we know about TB? Just a reminder that TB is a really tiny bacteria, and one of the implications of that is it's also very light. So once it's been coughed out, it gets to hang around in the air for a couple of hours, even after the person has left the room. Sometimes, I'm very conscious of that now when I walk into hospitals and so on. So, I don't get into lifts at a hospital because I don't know who was in that lift before me. So the person doesn't need to be in the room. If you've got cleaning staff who are cleaning in a patient who's got active TB's room, it's not good enough to just get the patient out because the air is still contaminated with TB. The other implication of it being so small is that it can really get down to the deepest, darkest delves of the lungs and settle in the alveolus. It's also a very slow growing and dividing bacteria. And the implications of that is it takes a really long time to get an adequate bacillary load to cause any trouble. have a very slow clinical evolution. They often start that they're coughing that they're having, it's been going for sort of 3 or 4 months. I think it's normal. Unfortunately, that also accounts for what happens at the lab. So it takes a really long time to grow TB at the lab level, and we've had to make a decision long before that. So we don't have 6 weeks to make a decision. It also unfortunately delays the diagnosis, and that means that people are often out in the community still spreading TB because they haven't been worried about their symptoms and they haven't been diagnosed earlier. The other trick TB has up its sleeve is that it becomes dormant. So any situation that it doesn't like, doesn't have enough oxygen, doesn't like the strong immune system coming towards it, doesn't have enough nutrition, it closes down and it becomes dormant. The implication of that is that you can be infected for a really long time before developing any evidence of TB disease. Also, that it's not a linear path. I always thought that you get TB infection, then you either get disease or you don't. And we're now starting to realize that some people who've got immune systems that kind of go up and down, you can have episodes of dormancy and episodes of activity. So also what's old, how does transmission work? If you give one good cough, it produces about 90,000 bacilli, and you only need 5 of those to cause TB infection. And these droplet nuclei remain in the air for a really long time. But after just 2 weeks of treatment, we reduce the amounts of bacilli by 99.9%. So if you really care about kids with TB, the very best thing you can do is treat adults with TB and make sure that they stay on their treatment. So I think that also has implications for when can somebody go back to work, and when can they go back to church or be part of their communities. After 2 weeks of effective treatment, we really do consider them fairly safe. So we also like the terminology of a source patient and an index patient. Those are not the same person always. The source patient is the first person in the setting to have brought TB to that setting. The index patient is the first person who's diagnosed. So people, you might have a child who's the index because they are the first person in the setting that's diagnosed, but actually the source patient is the grandpa who's diagnosed yet. So we've also, what's new? We no longer really talk about household contacts because we recognize that a lot of TB transmission occurs in the community. In the new guidelines, both the TB infection guidelines and the PED guidelines talk about significant contact. So we want you to ask patients questions with a little bit of nuance. Are you living in the same space as this person for more than one night? Are you spending frequent daytime periods together? And the period that we're interested in, because we know that after just 2 weeks of treatment, you're basically not infectious anymore. We're much more concerned about who you were around for the 3 months before you started treatment than who you are around once you start treatment. You ask the question retrospectively. So this guy's gotten divorced and he no longer sees his wife. Well, he was living with her last month, so she is still considered a significant contact and going a little bit beyond what is considered household contact. What's different in kids considering transmission? So TB behaves a little bit differently in a child's body. Its favorite place to be is in the lymph nodes that are in the sort of pulmonary area surrounding the trachea and the 2 main bronchi. It's very much nodal disease when they're little. And as they get older, they start developing more of an adult type picture. If it's all stuck in the nodes, it's not really likely to be coughing a whole lot out. So also less likely to have a high burden of bacteria itself. They have a very low bacterial load, and that makes them less likely to transmit. And the dynamics of a child's cough are just different as well. They have a very weak cough. They've got a very pliable rib cage. They've got a small little diaphragm. They've got small little airways and trachea. So children are very, very, very unlikely to ever cause TB in people. If you find TB in a child, your next job is to find who the source case could be. It probably wasn't this little child. The advantage for that is that kids don't need quite the same kind of isolation. I don't think it makes any sense to diagnose a child, a 2-year-old, and say that there has to be this very, very strict isolation from the rest of the family. But that also means that sometimes if you've got a 2-year-old and a 4-year-old in a setting, if they've been everywhere together and the 2-year-old has TB, we also need to wonder, was this 4-year-old potentially exposed to the same adults? And I would investigate them on that, on those grounds. So what's old about the pathogenesis? Basically, you breathe it in, goes into your alveolus, your macrophages try to attack it, so you can see that little white octopus trying to grab all of the red bacilli over there. And then one of two things can happen. Either it can remain as TB infection, where all of your macrophages surround and contain these bacilli, and it's a nice sort of stable situation, and it just stays exactly as it is. And that's sort of like security guards who found a shoplifter and have got him in handcuffs and are busy watching him, and it's all under control. And that's what we consider TB infection. But it's very important to remember that is real infection. Those are real live bacteria. They're just not doing anything at the time. And that can cause a gone focus. And a gone focus is where you get a whole lot of these macrophages with intracellular bacilli. They all sort of organize and cause what sort of looks a bit like an abscess. And it can just stay in that, just like that, or it can burn out and become cavitatory. And if the security guards lose control or the immune system drops, then unfortunately, firstly, these bacteria can multiply and they start spreading out. So the first place they're going to go is they're going to go up the bronchioles, up the bronchus. From there, they can get coughed into a different part of the lung. They can get coughed up to the back of the throat and swallowed, or they can, unfortunately, they sometimes get into the lymphatics or the bloodstream. And once they've gotten to the bloodstream, they can go absolutely anywhere. And that's a lot more likely to happen in kids because of their poor immune system. So unfortunately, kids are more likely to present than adults anyway, with extrapulmonary TB as their very first feature. This is pretty much what I've explained to you already. Most people exposed, we've probably all been exposed to TB today, and absolutely nothing happens 70 to 90% of the time. You breathe it in and you breathe it out. Of the time it will develop an infection where you've got your macrophages, you've got your bacilli just sitting there. It can become latent TB infection where everything sort of is in the, or you've got a 10% lifetime risk of that becoming active disease. And that's a little higher if you are a young child, if you have HIV or malnutrition. Once you've got active disease, either we don't give you any treatment whatsoever, and if we don't give you any treatment, you've got a 50% chance of dying in the first 5 years, 70% in the next 10 years, and if you have HIV that's untreated, you've got a 100% chance of death. Some people do actually manage to cure themselves just with their immune systems, but there's always a risk of relapse or reinfection, so we would always opt to rather treat. And if we do treat people, we're hoping for cure. Sometimes even with the best intentions, the treatment fails. Sometimes we manage to treat all of the bacteria, but people are left with significant disability in their lungs, their bones, their brains, and unfortunately, some people will die. So this is sort of the way we always used to think of things, but we now recognize that the latent TB is not as simple as we thought. Sometimes it sort of oscillates between infection and latency. So we now don't even about latent TB anymore. We call it infection, and we know that infection can lead to active disease, and we don't try to differentiate so much anymore. Another thing that's becoming quite a hot topic is subclinical TB. So these people who are sort of somewhere between infection and active disease, they are spreading TB, probably not particularly much, but they don't have any features on X-ray or any features in terms of symptoms. And that's because how we're going to manage these people is going to be one of the next big tasks for the next 5 years. What's different in kids about how this progresses? If you look at this, you can see that the younger a child is, the bigger the risk that they will get disease after they've been infected. So if you look here, the child that's under 1 has a 43% chance of going on to develop pulmonary disease compared to older kids. And a chance of disseminated disease or TB meningitis or death, you can see under 1 year old is the highest risk group compared to any other age group by a very, very big margin. So this difficult group that you were hoping you could get away with, you were hoping everything would be okay, they're hard to examine, they're hard to test, those are the kids who really, really need you the most. So what's old about how we can protect people from this? So obviously infection prevention and control measures, I'm not going to go much into that today. And then the two big tools we've got for kids, apart from getting the adults all on TB treatment, is vaccination with BCG and TB prevention therapy. BCG is very, very old. It's more than 100 years old, and unfortunately, it's still the only vaccination that we have that's widely accepted. Obviously, there are lots of fantastic vaccines that are busy being explored, but none of them are rolled out yet, and we're still sort of trying to see where those new vaccines should fit in. Should they be at birth? Should they be in adulthood? Should they be boosters? And I'm not going to chat too much about that. In the previous guidelines, it's very old. We've been using BCG since forever, and we always used to say give it to the child at birth. There was a period in HIV where we were worried that if we give this live vaccine to a child who's got HIV, we could cause disseminated BCGiosis. But the risk of BCGiosis is so small relative to the risk of dying from TB, especially in children who've got HIV, that the new guidelines recommend that we give BCG to everybody, regardless of if they are exposed to HIV or not. And I'll show you in a moment, but even regardless if they are exposed to TB or not. So why is this such a great vaccine? Firstly, it reduces everything in the cascade. It reduces the chance that you become infected after you've been exposed, just a little bit, not much. It's got a 50% chance of protecting you from pulmonary disease. It's got an 80% protective effect of treating from the very worst kinds of TB. So that would be TB meningitis, particularly. And in the TB hospital I worked at, many of the kids who came to me with TB meningitis, we looked for evidence either on their road to health cards or on their arms that they had a BCG. And almost 50% of those kids did not get a BCG, or we couldn't find any evidence of their BCG. Not all kids who get a BCG will have a scar, so that's not the best way to judge. But it's really a fantastic, cheap way of protecting kids from the worst thing that can happen to them. There are also some general benefits. So children who've had a BCG just have a lower all-cause mortality. So that's we don't completely understand why. Probably because we're priming that immune system pretty much as soon as the cord is cut, we're starting to get that immune system rolling. So they're less likely to die from gastro and pneumonia. It's also safe to give with other vaccines, and I don't think you can find anything other than hand washing that is a cheaper way to prevent disease. This costs about R2 per dose. BCG vaccine. We really love that. I'm a very big fan, and I don't have a conflict of interest. I don't get paid by them, but I just really love the vaccine. So what we've got in the new guidelines is we say that all children should get a BCG vaccine regardless of if they are exposed to TB or not. We've also upgraded what age children can get a catch-up. So any child under the age of 10 who didn't get a BCG at birth is allowed to get one as soon as it's noticed that they didn't get one. And in rural areas, I think you're much more likely to have babies who are born outside of hospitals. And whenever they get to you, it's always a good idea to open that road to health card and check if they got a BCG or not. If you've got children who are initiated on either TPT or TB treatment within the first 6 weeks after they get that BCG, we now recommend that they get a repeat BCG after treatment. So the reasoning behind that, if we give you a BCG, that's a live bacteria. It's M. bovis, so it's kind of like TB's cousin. And we're hoping to prime your immune system to react anytime it sees anybody from the Mycobacterium family. But that takes about 6 weeks to get going. So if we start TB treatment and effectively kill the vaccine we've just given you, your immune system's not going to build up any response. But we can't take the risk of delaying your TB treatment or your TPT. So we would rather repeat that BCG. It's considered very low risk, but we don't have very much evidence for this. And if it's possible, we'd obviously like to do that when your immune system is in top form. If it is a person living with HIV, we'd rather do that once they are on ART and have a good CD4 count. But I think also important in rural areas, it's considered acceptable to open a vial of BCG, which has 20 doses, for only one baby. So, you have to use it within the next 8 hours. And often we find that in places where there's only one baby born every couple of hours, nurses are reluctant to open a vial that they know they're going to have to throw away because there's nobody even in the labor ward. that's absolutely fine. 40 Rand for a vaccination is relatively cheap compared to any of our other vaccines. So I'm happy to answer questions on this. This is quite new, and this was actually one of the things that delayed the guidelines, because it's really very different to what we had previously. So the reasoning behind why, even if I know that this is a baby who's TB exposed, I would still give a BCG, is because we don't want to make things confusing at maternity wards. So we want the maternity ward to just know everyone gets one, and we can make the tricky decision of, okay, do we need a repeat? We would rather have that for the people who are more experienced in managing TB. So where are you going to fill it in if you give a repeat BCG? Luckily, the people who made the Road to Health card gave us a few extra spaces at the bottom. So that's where you can capture a repeat BCG if you do need to give one, and ideally with an explanation in the text of the Road to Health card on why you did that. So you've seen all of this, and you can see that we can prevent at infection stage. We rule out that whole long story I gave you. We give a child who's got absolutely normal lungs, we can keep their normal, healthy lungs. So if we can treat infection with TPT, it's very, very good bang for buck. It's not very sexy medicine, because these are kids who are not sick. We're trying to prevent them from getting sick. But it's very important to remember that we are treating real, live TB. So what's old about TPT? And I think this is, we always used to give TPT to children who are under 5, if they were household contacts. We also recognize that people who are living in a home where somebody's got TB, and if they've got HIV, should get TPT. That's relatively old. We also always want to actively exclude active TB before we give people TPT. And we used to call it IPT, because the only thing we gave anybody was isoniazid. And for RTB, the recommendation was to give a combination of levofloxacin, high-dose iron H, and ethambutol. What's new? In the new TB infection guidelines, the first thing is, you can see we don't talk about latent TB anymore. It's called TB infection. Who is eligible for TPT? We now use what's called a TUT approach. So that's targeted, universal, test, and treat. Because we're not going into the street and doing this to everybody, we're targeting which groups are very high risk. So those high risk groups are significant contacts, people living with silicosis, and everybody within those groups should get tested. So the reason why we test everyone in those groups is because in South Africa, when we did a South African prevalence study, we found that many people with TB, it was really high, I think it was up to 40% of people with TB didn't actually report any symptoms. So symptom screening alone is not enough to pick up people with TB. And for adults or people who are older than, who weigh more than 25 kilos, we're going to suggest doing a sputum sample, whether they have symptoms or not. We also now give TPT for everybody. So if you diagnose an adult with TB, you tell them to get their whole household together, bring a picnic basket, because you're all going to be at the clinic together, and everybody in that setting qualifies for either TB or TB treatment. So I think the rule of thumb is that if you've got significant exposure, you never leave with nothing. You're either going to walk out of the clinic with TPT or with TB treatment. We still, of course, need to exclude active TB. And in the new guidelines, we don't actually have anything for children or adults. We classify everybody under 25 kilos as a child, and everybody over 25 kilos we're going to manage as an adult. For a few reasons. Firstly, the drug that we can give you, probably a child who's over 25 kilos is going to have adequate physiology to manage the drug as an adult would. A child who's under 25 is also going to be the one who can't give you a sputum sample and needs different medications. So we know that it's really difficult for people to get sputum samples. But as I told you earlier, children are so likely to be porcibacillary that if they are asymptomatic, it's no longer expected that a child who comes in who's got a TB contact and is growing well and everything's good with that child does not need to give you a pulmonary sample. You can start the TPT just like that. If you have a chest x-ray available, that's fantastic, but it's also not, that should never be a barrier to starting TPT. So our attitude has changed a lot. you'd rather start TPT, and then if something changes, you can always upgrade to TB treatment, but we really don't want people leaving with nothing. We've also got a few more options, which is nice, but it does make it a bit more complicated. So all kids who are under 25 kilos and HIV negative will get 3RH. Because rifampicin doesn't play nicely with the ARVs, if they're HIV positive, they unfortunately still need to get 6H. And for people over 25 kilos, we've now got a great new drug called 3HP. So that's rifapentine and INH. And what makes that so great is they only have a dose once a week for 12 weeks. That's really, really good for patients. They're a lot more likely to complete their treatment if they only need to get this once a week. So unfortunately, people who are living with HIV and are not doing fantastically on their ARVs, we generally won't give them 3HP because we know that the rifapentine might affect their dolutegravir levels in their blood, and we can't afford that little hiccup in dolutegravir. So they would still get 12H unless they are fantastically well controlled on their dolutegravir, and we can afford a slightly lower dose of the dolutegravir in the blood. For DRTD, we're recommending 6 months of levofloxacin. In the 2019 guidelines, there are still 3 options available, and we're still waiting for a government memo that is signed to say that we're moving towards 6 months of levofloxacin, but that is adequately captured in the 2019 guidelines. So you can go ahead and do that. And for INH monoresistant TB, we give 4 months of rifampicin. So what's different in kids? So again, no 3HP if they're under 25 kilos. If they've got no symptoms, they don't need to give you any kind of sample. You can see the decision algorithm later on how to work it through for them. But other tests like a skin test and an IGRA, that's not going to help you because that doesn't tell you the difference between infection and disease. So we're really trying to make it very simple and really trying to push you to put kids on TPT. What's going to be different in rural areas? So the first thing is, you probably can tell me better, but coming to facilities is not that simple. I've done outreach where you can really see there's a river that blocks these people. There's no taxi and there's only transport on a Sunday, and the clinic is closed on a Sunday. So we really need to rethink, how can we get TPT to community level? So often the issues that I'm told about are that there aren't scales on outreach vehicles for little. There aren't registers. Sometimes we hear about pharmacists who are not happy to give 3RH to the outreach nurse to go and give at community level. So I think within your own settings, you can think about what shared care community health workers that are working with the outreach nurses and facility-based doctors. You say, look, I've got this kid, here's his road to health card, he's growing just fine. Are you happy with me to give this child 3RH or not? Also different in rural is that chest X-ray access is sometimes reduced. So symptoms and sputum-based decision-making is probably going to be the way we're going to have to go for these kids. The follow-up can be difficult. So you might want to consider some shared care models where maybe this child comes once to a facility and a community health worker is doing the follow-up for you. But remember that you can always start the TPT and move towards a treatment if necessary. People are often worried and they say, no, but what about if I start this child on TPT and he's actually got TB, won't I cause resistance? That's incredibly unlikely, because if this child is asymptomatic and was so well, he probably has so few bacilli that you need quite a big population of bacilli to breed resistance. So that's not really something that you should be worried about. And something else you can consider in rural is just supplying multiple months of TPT. So with 3HP, we're often finding people actually give the entire course of 12 doses in one go. So you'll have to just see what works for you and in your setting. But I think for TPT in rural, we really have to work at an outreach model. Okay, what's old about TB diagnosis? You all know that all kids who come to all facilities for whatever need to be screened for TB. We know that you need to take a history, and that history will be looking at their contact history, any symptoms and risk factors, examining the entire child, not just the one that's coming with the problem. Investigations. Chest X-ray, I would say, is the mainstay of diagnosis in kids. Understanding what a TB skin test is good for and what it's bad for. And then what can your lab do for you? So your lab can only really do 3 things for you. It can either do a night test, and that's like your expert, it can do a smear, or it can do a culture, and there are a couple of different sample types that you could send to the lab. And then one of the other ways that we diagnose TB treatment, when you've guessed, is that the child gets better. And then you realize, okay, we did a good job. So what's new about TB diagnosis? If you look in the new TB guidelines, and this should be in all facilities, if you look at what's different in adults and in kids, we no longer say that the child has to be coughing for 2 weeks. So a child who's coughing for any duration would count as screening positive. We also, probably the commonest symptom I've ever seen, it's not what's in the book, but what I see is kids where the mom can't even really tell you what the problem is. She just says, yeah, I don't know, this child, he's not right. He's not okay. He's not himself. So those vague, strange bits of history, and that would be like fatigue or being less playful. And that's incredibly common, that the mom can't quite put her finger on what the problem is. So I personally think that cough is a little bit overrated in terms of pediatric symptoms. I think that vague, just a kid not being the kid he normally is and not having a good appetite is probably more likely. So this is the government's screening tool. I'm just making you aware of that 2 weeks is no longer relevant. But when you're taking a history, knowing who your high-risk candidates, who's already got a half a mark for TB, and those would be your kids under 2, your people living with HIV, as well as kids who've got severe acute malnutrition. They are high-risk groups for 2 reasons. Firstly, because if you get it wrong, those are the children who are most likely to die. And secondly, those are all children who have independent risk that's higher than the kids who don't have those conditions. They're more likely to get TB, and they're more likely to die from TB. So your red flag should already be up when you see one of those kids. So also remember that all kids do have a contact history. I mean, they picked up the TB from some adult or adolescent, but most will not have a known TB contact. So if you ask the mom if there's anybody at home who's got TB and she says no, it does not mean that the child doesn't have TB. So be very conscious. And it's not the mom's fault, and she wasn't lying to you. The child might have be from somebody in the taxi, or somebody at creche, or somebody who's waiting in the way. So as I've said, a lot of the time the symptoms are really subtle right at the start. Don't judge yourself if you can't quite put your finger on it. Pulmonary symptoms aren't always the classical symptoms. So remember I told you that it likes to be in the lymph nodes in kids. They aren't going to have this cough that adults will have. They usually will have signs of pressure on the airways. So it'll be wheezing, bit of shortness of breath, maybe getting tired, and maybe respiratory distress. And when you examine those children, you might pick up slightly different air entry on the one side to the other side. So in TB, we like the story of chronic symptoms because that eliminates a lot of other things in the differential. But sometimes it's quite acute. Sometimes it can be very recurrent and quite varied. So I also think of the repeat customer as a child who should be considered to potentially have TB. This week they came in because they weren't eating, and then it sort of got a bit better when you deworm them. And now they come in with fever, and you thought it was teething. And 2 weeks later they come in and they're coughing. And then the mom says, I don't know, he seems to have a headache. So if the things don't completely align, and it's also a varied problem, the repeat customer, I think, is a good patient to consider TB. So also difference in kids compared to adults, that often the thing that makes you think of TB is not going to be something to do with the lungs. It's going to be a child who's got lymph nodes. It's going to be a child who's just not great, and he's sort of vomiting, and he's been complaining for a headache for 3 weeks, and he used to play soccer every day, but now he just lies and sleeps. That could be the very first thing, even though he's growing okay, even though there's no history of anything to do with his lungs. Bones and joints. Kids like to be kids, especially little kids. They like to climb, they like to learn, they always proud of themselves for getting to new milestones. If anything's going backwards, that can be a sign that there's either TBM or something in their bones, joints, or in their spine. TB abdomen can be quite difficult. They often have very big livers. They can have abdominal distension. They sometimes have abdominal pain, but I've always found that these kids actually have less pain than you would expect. And often you can feel that there's something going on in that abdomen, but you just can't quite pinpointed. You can't say it's a mass. It really feels like it's just sort of sludgy. And I think that's from lots of the Peyer's patches that have been infected and very small lymph nodes. So you really feel like you kind of digging into something that doesn't feel right, but you can't put your finger on it. And skin, I've got plenty of slides of skin TB. Anything funny with the right history can be TB. And also a bit more particular in kids is that they can have a painless ear discharge. And if there's a mastoid process that's infected with TB, it can affect the facial nerve, and facial asymmetry can sometimes be the very first feature that brings the child to care. So anything with a blood supply can get TB. Anything a bit off, no matter what symptom it is, you don't want to know the weird questions I get. And if it's the right kind of kid, he's not growing well, he's got a TB contact, and he's thinking funny, it could be TB. So this is the way I like to approach who actually needs to move on to diagnosis. So to me, being assessed for TB is the bus, and there are 5 ticket booths to the bus. Either you screened positive, and we've looked at what those 4 screening questions are. You have a contact. We've discussed what a contact looks like. You're high risk, so you have HIV or malnutrition. Any severely ill child, I don't even care what the problem is. If it's shocked gastro, if it's vomiting, if it's seizures, any sick child in South Africa, TB should be somewhere on your differential, and then your repeat customers. To me, these are the 5 groups of kids who I think deserve an assessment for TB. Once you've assessed them, you either correct and you diagnose TB, then you do some tests to see if you can confirm it, you notify them, you treat them, and then don't drop the ball there. You have to retain them in care. Or after looking at that, you say, okay, they got on the bus, but I don't think it's TB. I'm going to treat for something else. Some of those kids will qualify for TBT, and we're going to follow up because maybe I was wrong. So where do these skin tests fall into that? So I've kind of shown you what the symptoms are, what the history is, who the kids are that get onto the butts. Now we've got to look at the butts of how do we actually assess these kids. So remember that a TB skin test is not actually testing for TB. It's testing the child's immune system once it's exposed to TB. So we know that if a child's previously been exposed to TB and we show it that protein again by doing a TB skin test, there's a chance that it'll cause a hypersensitivity reaction that we call the Mann reaction. So all that this shows you is that this is a child who's previously had exposure to TB, and there has been TB in the body. So what you need to get an accurate TB skin test is you need enough time, okay? Everything in TB is slow. So if a child day and you do the Mann-2 test tomorrow, it's going to be negative because the body takes some time to process and recognize what it's been exposed to. So this will only be 2 to 12 weeks ago. You need to have a functional immune system because we're testing the immune system. So if you've got a totally kaput immune system, it's not going to cause a reaction. We need the correct technique in doing the test, but we also need the correct technique in reading the test. And that should be 48 to 72 hours after administering the test. So this is a really useful test when you've got a situation where you've got a sick child and something just feels off and you don't really know and you're not really sure if it's TB or not. Or it's a child who's got severe acute malnutrition and you know that part of your job is to exclude TB in a child with severe acute malnutrition, but there's no history of a contact or anything like that. In that setting where you've got a clinical reason to test this child, if it comes back positive, that's incredibly helpful to say, yes, I think this is TB. So it's a good way to differentiate between TB versus something else. It's not a good way to differentiate between TB infection and disease. And of course, I'm giving you the absolutes, right? That's a different story if I was in Switzerland and there's a child who's been exposed. There I might consider doing a TB skin test. So just remember that BCG, which is a live microbacterium, can also cause a slight positive reaction. And that's why we do allow up to 5 millimeters as a positive reaction. Because we say, well, that's probably because of other microbacteria that you've been exposed to, and BCG would be the most likely culprit. But in a child who's immune compromised, we would take anything more than 5 millimeters as a positive. In a child who doesn't have HIV and is doing otherwise well, they would have to get a TST that's more than 10 millimeters to be considered positive. This is really not a great test. It's a helpful test when it's helpful, but when it's negative, it doesn't mean that the child doesn't have B, unfortunately. Okay, so there you can see how to do the test and take it and to measure it. I'm not going to go into that right now, but you can always contact me later for that. What's kind of newish about TB diagnostics? I don't want to say it's new, it's been around for a while now. And this is really the wild west of TB because I've seen such varied uptake of urine lamb tests. Some people don't trust it at all. And other people have just decided that they're not doing any more sputums anymore because they like this test much more. It's much easier to make your diagnosis. So what is TB lamb actually looking for? Lamb, I'm not going to even try and say that long word, is a substance that's created only in actively replicating TB in the cell wall. So if you've got a positive lamb test, it tells us that you have got actively replicating TB, and it's detectable in the urine of people who have active TB. Now, we only recommend this for the sickest of the sick, right? So it's people who are living with HIV with a very low CD4 count or are ready for hospitalization. And we think that some of the reasoning there is that they've got quite leaky glomeruli. So that's why lamb comes out a little bit better in these adults. We also know that there's a group of patients where we can't afford to get it wrong because they're really, really sick. This isn't a very sensitive test, and all of the tests were done on adults. There's very little literature to actually show how good or how bad it is in kids. So we're sort of using a little bit of, we assume it works the same way in adults and in kids. But, I often get this query of somebody who had a lamb test and it was completely inappropriately done. They're not the children who should have had a test done. And then somebody's asking me, should they start this child on TB treatment? And I honestly don't have an answer. I really would encourage you only to use urine lamb where it's done. But if you look at the guidelines, we also say this is to tell you that the patient has TB. It doesn't help you to decide if they've got drug susceptible or drug resistant TB. So if this is positive, you can start your patient on treatment, but they still need to get a sputum sample. Then we move on to the lab test. So what can the lab do for you? They can do one of three things. Either they can look for a little bit of TB DNA in whatever sample you sent them, and that's in a night for a gene expert, or they can physically look at the sample and they add some dye to it. I'm not going to go into details, and they can look physically for TB that they can see with a microscope, or they can take your sample, prepare it, put it in a really fancy environment with lots of food and perfect temperature, and see if they can actually grow TB. I'm not going to go into much detail about how that works, but that's pretty much, those are the only options of what the lab can do for you. Night testing is the preferred option, and the main reason is that the turnaround time is really good. We used to just talk about experts, and that's just one brand, but the using BD Max and Cobas as well. And one of the advantages with BD Max is that looks immediately for RIF and INH resistance right off the bat, whereas we would only be able to look for rifampicin resistance. And then we could send a second sample that could look for INH and some of the DRD lectures. I'm not going to go into too much detail about this right now, but I want you to be aware and to really read your results carefully. See if they're giving you an expert or a BD Max result, and I'll show you why in a moment. If you look at these NART results, these are the first one here is a patient in blue. I've highlighted what test was done. So the first one is a Gene Expert Ultra, and you can see that they didn't pick up any DNA of B, and because they couldn't pick up any DNA, they also couldn't pick up any DNA that codes for resistance. But in the second test, you can see that it says it's a BD Max test. And this patient, they did find a little bit of DNA that indicated there was TB. And they also found a bit of DNA that showed that it was RIF susceptible. So they didn't find any mutations that code for resistance. In the second picture here, you can see that it's a BD Max test. It's a positive test because they found a bit of DNA that indicates that there's TB. They also indicated that they found no resistance to rifampicin, so they didn't pick up any mutations. But suddenly, here's a new addition. There's a pink area, and that shows you that they picked up INH resistance. So they found one of the mutations that codes for INH resistance. So this is a patient who's got INH monoresistance because they're RIF susceptible and INH resistant. Now, I'm sure you're wondering, why didn't they tell me that the previous patient was INH susceptible? Why do they sometimes give you the INH, sometimes they don't? The reason that the lab does that is they're only looking for certain mutations for iron H resistance. So they look for the commonest 80%, but they know that just because they didn't find those doesn't mean that they don't exist. So they will tell you if they find resistance. If your BD max result doesn't tell you anything, it means that the lab is 80% sure there's no resistance, but they don't want to commit to that and say that it's iron H susceptible. So that's why you'll get different results on your BD max. Sorry, I'm going through this so fast, so I can always explain that later separately. So what's different about these lab tests? The first thing is that a NARD test is really pretty useless. Okay, so if you've got a positive culture, then a child has got about a 70 to 80% chance of having a positive NARD test. If they are negative, it's usually around about 30%. And how many are culture positive? Very, very few. So even children that we are very sure have got TB because they've got the contact, they've got X-ray, and they've got losing weight, and they've got all of the reasons that we really think that they've got TB. Only a 10 to 50% chance that we will actually grow TB if we send it to the lab. And of those, only 70% will have a positive NARD test. So you can see here that a NARD test, you trust it so much in adults, you absolutely cannot trust that to exclude TB in children. It's very helpful if it's positive, but again, around 35% of kids who have got TB will actually have a positive gene expert or NARD test. And a smear is just wasting your time completely. So only 1 to 7% of kids who've definitely got TB will have an active smear. And you'll see that in the new guidelines, we actually recommend not sending a child sample for a smear because you're wasting sample. It's a lot of work for the lab. And I think I've seen 2 positives in children under 10 ever. So it's usually a lab error if you find it positive in a child. So really save your specimen, send it for a NARD test as your priority test, and then a culture as your second prize. And that is in the guidelines. You can find it there. Now, what sample are you going to take for kids? It's so easy with adults, right? You send them around the corner, you tell them to cough in the little bucky for you, and you send that away. That's still the first prize in kids, to get a sputum. An induced sputum is where you have given the child something to cause a bit of a cough and to maximize the amount of bacteria that you can get into the airways, and then they sort of suck that out. As we mentioned, once a child has coughed up, once you've got bacteria that have gone from the alveolar up the bronchioles up to the trachea, it goes to the back of the throat. From the back of the throat, it gets swallowed, and then it sits in the stomach. So that is the reasoning behind a gastric aspirate, that what's in the stomach often comes out of the lungs. But that's not an amazing test, and any of you who have done that know that it's a really unpleasant test for children, and they need to be starved for 4 hours. There's some evidence now that we can use a nasopharyngeal aspirate, but it's not very accurate. A tracheal aspirate, if they're intubated, or a bronchoalveolar lavage, those are children. And then the new kid on the block is stool. So we're very happy we added stool into the new guidelines, and the NICD told us a few weeks ago that they were going to implement it, and that's going to be rolling in by the 1st of April. I see that the memo did leak, so I'm kind of secretly happy that the memo leaked. We are going to be implementing that, but I think for the moment the labs are still busy doing refresher training. So before you send a stool, just make sure that your lab is ready to accept that stool. And the reasoning for why a stool would work is the same as a gastric aspirate. So what ends up in the stomach, a certain percentage of that will go down into the stool as well. You don't need to know the details of what the lab is doing for that. And I saw that on the Rudasa group, this memo was shared this morning. So the important thing is that you need very little stool. The lab would prefer a slightly firmer stool, but a loose stool is also acceptable. Don't ever fill the bottle above above halfway. And you're actually supposed to send a stool and a respiratory sample. But I also want to tell you that this is not going to be the lifesaver that we wish it could be. It's nice if it's positive, but it performs even worse than gastric aspirates and sputums and so on. So send them with pleasure. But if it's negative, it certainly doesn't mean that this child doesn't have TB. I'm a PI on a stool sub-study where we tested stool on 80 children who are TB contacts, and not one of them came back with a positive sample. So granted, those are healthy kids, but I just want to tell you again, there is no perfect test for TB in kids. You're going to add it all together, make your best bet. Okay, so what's different in kids regarding chest X-rays? So firstly, we will accept an AP. In an adult, you'd prefer to get a PA, but kids have got little tests, so there's very little difference between an AP and a PA. We would always like to have a lateral for children who are under 5. I still like doing them under 10. And just having a general approach to how to read a child's chest X-ray, looking at the quality, because the quality will affect how you interpret the results. Also knowing that in kids, sometimes they actually have chest X-ray features before they even have any clinical features that the parents have picked up on. And I'm only going to talk to you about one important thing here, and that's lymph nodes, lymph nodes, lymph nodes. So if you look at this picture that I've given you, that's where the lymph nodes live. And if you look at X-ray, you'll see what enlarged lymph nodes look like. That's very different to what you're looking for in adults, where you've got these big apically sort of cavities in the apex. In a child, you're mostly going to be looking at this area, and obviously as they get older, they can have a slightly more adult picture. There are many, many different types of TB manifestations. I'm not going to go through all of them due to time, but you can see here on the purple, these are the things that you're going to be looking for in a child's X-ray when you're looking for potential TB. So mostly just trying to get you to be aware that it's a very different clinical picture on the X-ray compared to an adult. We also classify certain findings on the X-ray as severe and some as non-severe, and that will be important in a moment. I'll explain to you why that matters. And the other thing is that this is a team sport, really. My whole phone is full of chest X-rays that people send me. I don't know if I'm getting them right all of the time, but we try and come up with the best answer that we can together. And the only way you're going to get good at this is to practice, 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 and eventually you'll be a little bit better than you were before. So the big things to look for here, only showing you these top X-rays are all just looking at nodes. And what I want to show you is on the lateral. On the lateral, a normal X-ray will have a bit of a Pac-Man. So you can see this picture where there's a white arrow. You can see that the full circle. They've made it a graphic over here. The blue area here, we call the donut sign. If you've got a donut instead of a Pac-Man, then we would really think that that's TB lymphadenopathy. If you look at this picture, it says B. Oh, sorry, I don't actually like that picture because it's so obvious. Anybody could tell you that something's not right there. But if you look at D, it shows you what part of that makes that very likely to be TB, and it's that bottom quadrant. So you should have your Pac-Man mouth over there in that back quadrant. Sometimes it's in a slightly different area. But that's what TB lymph nodes look like on a lateral chest X-ray. You've got a couple of APs over here, and you can see that it's very full on the right hand, or on the right and on one on the left hand side. This bottom picture on my left hand side is a child who's got a cavity. You can see that even if it's a very little baby, but he's got lots of things going on in that X-ray, including happening. Which other ones? I wanted to show you these ones on the right hand side. That's a Miller picture. And what makes that a Miller picture is that you can see speckles and they're throughout the lung fields. And that's a very important finding, and I'll explain to you why in a moment. And then the last one I just wanted to show you was an expansile pneumonia. If you look at this picture at the bottom, you can see that you really get the feeling that that upper lobe is expanding like a balloon that's full of water. And you can see on the lateral, it looks even more like it's expanding outwards, and that's called an expansile pneumonia. And that's sometimes we do find with TB. So if you look at everything we've discussed here, this is all that you have, right? These are the only things you have to diagnose TB. Once you've done your screening, your history, your clinical examination. So TB skin test works in some kids. Previously, we used to say no, not in kids under 5. Sometimes it's helpful in kids over 5, but the problem in South Africa is most kids over 5 have been exposed to TB at some point in their life. So we'd have to discuss that one. A urine lab test, only for very few people. And a chest X-ray, we really want an AP and a lateral. If you're sending off lab tests, we'd prefer the sputums, and sputums are okay. But maybe you've got a child who has a big lymph node and you can do an FNA, and that's going to be your best bet. So just looking carefully what you want to send to the lab. Is it going to change your mind? And knowing that not one of these tests is exceptionally accurate. You have to put your whole picture together. So we've discussed here what assessing for TB would look like, what diagnosing it and excluding it would look like. And this is the best isn't ever in the guideline. We try to put it all into one diagram for you. So this is something that you can use at any level of care, whether you're in ICU at a pediatric hospital or whether you're doing outreach. You'll just have different options available. And this is what we'd really encourage you to use if you're not sure if a child's got TB. You can see that in the gray area, this is how you get on the bus. So either you've screened positive, or you have a contact, or you are somebody who's got very high risk features, or have a really, really clear picture that looks like TB. Then we say, if you're getting on the bus, you have a cough, especially if it's like a chronic cough, do you have unexplained fever or anything like that? Are there any danger signs? Because if there are danger signs, this is a child who's not breathing, this is a child who's not conscious. We first sort that out, and then we move you down into the algorithm. If you have none of those, and you came onto this bus because you have a contact, we'll say, okay, you seem fine. Do you have any of the risk factors that make you incredibly high risk for advancing disease? So in other words, are you under 2? Are you living with HIV? Are you acutely malnourished? If not, then we give you a second chance to say, listen, this child had these problems for more than 2 weeks. If not, then we say, okay, let's give you a chance. Let's give you antibiotics, or let's ear infection, or let's worm you, or whatever your problem was. Let's try and treat for something else and see you again in 2 weeks' time. If you came onto this because you were a contact, even though we're going to treat the other problem of yours, we're going to give you TPT, and we're going to review you in 2 weeks' time. If however, you were one of the high risk groups, or you did have features that were for more than 2 weeks, you move on into the yellow section. And the yellow section is encouraging you to actually do some investigations. First prize would be a chest x-ray and some sort of test that you can send to the lab, or a urine lamp test if you're eligible. Some kids, it would also be a TB skin test. And once you've done those, either you've got something in the pink where test x-ray or one of those other tests looked as though it might be TB, you're just going to treat for TB. If you could not do either of those, or you did those and they came back negative, then we try to say, listen, did you have a household contact, or did you have a positive TB skin test? If yes, you come all the way down this algorithm, so we're probably going to treat you anyway. So those kids, unfortunately, even though they've got no x-ray or no evidence from microscopy, those are kids that we would treat anyway. If you don't have any of those, we ask you again, do any of those signs and symptoms really look like classical TB? If you say, yeah, actually, I mean, this is a child who's losing weight, coughing, he's got all the features of TB, okay, fine, we're going to treat you. If you think no, we will say, okay, we'll see you again in 2 weeks' time, and we'll reconsider the TB diagnosis at that point. But if you really aren't sure, we've given a score sheet on this, and this is it's adapted from a WHO score sheet. So this gives you certain points, a number of points, depending on this far into the algorithm in the first place. You've been coughing for more than 2 weeks, you've had fever for more than 2 weeks, you've got reduced playfulness, weight loss, coughing up blood, night sweats, enlarged lymph nodes, cardiac tachypnea, and we look at your score. With that score, you get more than 10, we would probably recommend that you start TB treatment. If you are experienced, you're probably never going to use this because you trust your gut well enough. But if you're really unsure, or if you're a nurse who's sitting at an outreach clinic and the doctor only comes every 3 weeks and this patient can't wait, this is a very blunt instrument to assist on deciding between TB treatment or not. So the way to remember the score is you've got 10 fingers, 10 is normal, 11 is not normal. If it's 11, we would recommend that you start treatment. This is very much just a guide. If you feel confident in not needing to use that, we would obviously rather trust your overall interpretation. But this is really aimed at something that makes TB diagnosis possible at any level of care, and completely independent on how experienced you are. Okay, so what's different in rural? I'm sure you can see from this that actually not all that much. So even if you were sitting in a city where you've got everything, maybe there it's easier for us to get a sample to the lab, but the lab tests, we can't really trust them anyway. chest X-ray, I think that certainly is a lot easier in urban settings. But even in the best settings, it's always going to be a little bit of guesswork and putting it all together. I think it's very important for you in rural to not all just because you can't get lab tests. In kids, it's actually, it's like cooking. You're going to try a bit of this, try a bit of that, and you get a little bit of assistance where you can. You have to be comfortable being uncomfortable, where sometimes you're just going to make a call and you're going to say, look, I'm going to start this child on TB treatment because I think that's the safest route, and you just have to accept that decision. And you are going to have kids in your life that you start on treatment, and you were probably incorrect, but that's much better than missing the kids because you weren't sure and you didn't know that you had enough information. Remember that HIV testing is always a good idea. I've seen so many stories of, oh, this child was unexposed, and then surprise, surprise, the real answer was actually that the child had HIV, not TB. Be very careful of the child who's just been started on ARVs. Remember, once you switch from the immune system back on, sometimes the TB symptoms only show themselves then. Use your referrals wisely. If you are in a setting where it's really difficult for this child to get to the hospital, then think carefully, what can you do to make the hospital trip as fruitful as possible? Maybe you can take the sample that you send into the lab and send it so that the doctor who sees him at the hospital already has that result ready. Maybe you can do the TB skin test so long and do the HIV test so long. Maybe you can fill out a form for the X-ray so that when that child gets there, this can be done better. But I would strongly recommend you referring the question and not necessarily the patient. You can't hear anything on the lungs, I probably won't hear anything either. And that doesn't mean that the child does or doesn't have TB. I'd strongly recommend that you discuss patients rather than simply referring them. And I've seen that often, especially in the Eastern Cape. Everybody refers, and meanwhile the hospital doesn't have tubes to do a gastric aspirate and the X-ray machine is broken. And now we've wasted the family's money and there's nothing that's going to be done differently at the facility. Okay, I think I've kind of covered everything there and I'm running way behind time. So what's different regarding treatment? Until very recently, we used to treat all kids with 2 months of RHZ and then 4 months of RH for uncomplicated TB. And we used to add the ethambutol only when children had complicated disease. And for a very long time, children in South Africa have been treated with 6 months of rifampicin, iron H, and ethionamide if they had either miliary or TBM. In the old days, we've come a long way with DRTB. We didn't give bedaquiline for kids who were under 6 and no delaminate for kids who are under 2. Now we give that to kids of all ages, and I've given it for kids as young as 4 months. We also used to have very long regimens for kids who had DRTB. What's sort of much better now is we've now got flexible formulations of RHZ and RH. My warning to you there is that the boxes look almost identical. Make sure you know what your patient is getting and try and look at the boxes and the tablets yourself. We used to leave ethambutol out under the age of 8 because ethambutol in very high doses can cause visual acuity problems. Problem is that so we only reserved that for kids who we really felt where the risk was worth the benefit, but it's now considered a safe drug because of the doses that we're using it at. Ethambutol is what's considered a good companion drug. It really helps to protect the drugs in the regimen from resistance, but at the doses that we're using we're using Labrador doses. The reason that makes a difference is that it makes it a lot safer to give to children, even when we can't do visual acuity testing. Just remember that kids do so much better than adults on their drugs. They don't, and children have also got much better treatment outcomes. Don't forget that if you're starting a child on rifampicin and they are on lopinavir or ritonavir, you need to boost with extra ritonavir every time that they get their lopinavir ritonavir, so that's usually twice a day, and you're going to give that for 2 weeks to 4 weeks after they've finished their TB treatment, because there might still be some rifampicin in the system. If they are on dolutegravir, you're going to add a knockdown dose of booster dolutegravir while they are on rifampicin, and that also covers the tail end, so you carry that on for 2 weeks after finishing TB treatment. So that's different in kids and in adults. What's new in TB treatment? In the new guidelines, we are allowing certain children to be eligible for treatment shortening. We've got two different scenarios. The one is where there is a chest X-ray available, and the one is where there's no chest x-ray available. The reason that it matters if there's a chest x-ray, you need to know, is there any chance that this child has got some causes of severe TB? So does this child have lymph nodes that are blocking an airway? Does this child have cavities? And if any of those, they wouldn't be eligible for treatment sorting. That's why if there's a chest x-ray available and we can be sure that things don't exist, we're a little bit more lenient on who would qualify. I'm not going to go through all of this. You can find it in the guidelines. I think the important part really is just the age group. So under 3 months is not eligible. If we have got an x-ray and you're under 16, you qualify. But if you don't have an x-ray, you have to be under the age of 8. And the reason for that is kids between 8 and 16 are, they start getting a bit of an adult type picture. Without an x-ray, we can't be sure that these kids don't have cavities. And that's the reason for the difference. But also important here is remember that you have to actually qualify 3 times for treatment sorting. The person who's seeing you at the beginning, read all of this and say, yes, you meet all of the criteria, and my plan is to give you 4 months of treatment. But the person who reviews you at 1 month, if they don't feel that all of these symptoms and signs are looking better, can veto the original decision, and they can say, nope, we wanted to give you 4 months, but I'm changing that now to a 6-month regimen. And the person who sees you at 4 months also veto the decision, because at 4 months, you're supposed to be completely healthy and having a good weight trend. And if that isn't the case, then they can say, nope, we're adding on those extra 2 months. So the difference in the regimen is really pretty simple. It's basically just 2 months less of the continuation phase. And there are nice tables in the guideline on exactly how to do that. So what's going to be different in rural? The first thing is it really helps to know your pharmacist. So ask your pharmacist to correct you if you're doing funny things with TB medications. Try to order medications, especially the DR-TB medications, before the child comes for follow-up. And that also counts for TPT. So sometimes medications expire and there's a family who's going to a lot of trouble to come and see you, and you don't know that the pharmacist has actually just thrown out all of the rifampicin and this child is coming to get it. Make sure you know you've got stock when you're expecting a child to come in. Think very carefully what the best location is for treating these kids. In rural areas, sometimes a child who's really struggling to tolerate these medicines and is vomiting a lot, they might need slightly longer admissions. And hospital, I hate keeping kids in hospital, but if coming back to hospital is a financial and logistical nightmare for this family, you'd probably keep the child in hospital for a little bit longer. Also think, who's the best person to administer the treatment at home? It might be a mother, but it might be a granny. If the granny really can't read and she can't work out how many mils, is 5 mils or 6 mils because she literally just can't see properly anymore, maybe there's a next door neighbor who would be the best. In a lot of rural communities, in farm areas, we sometimes involve people like farmers, sort of the farmer's wife or something, because she can keep them from the kids and manage it that way. So think very carefully who your support team could be. Also remember, that's if this patient gets worse, who are you going to call? What can we do? How can you get back to the clinic? Who's the nurse at the local clinic who will know your story and that can phone the doctor if there are any problems? And always a good idea to discuss any patients that you're worried about early. Even if you aren't planning on referring them, it's just good that in your referral pathway, there's somebody who's aware that there's a child who's causing a little bit of trouble, you're a little bit worried about, and you do that shared care right from the beginning. This is a whole lot of stuff we didn't do today. Tons and tons. I've got a 3-day TB training course that I tried to condense just the most important bits for you. I'm aware of all of the gaps, and those are, most of those are nicely covered in the new guidelines. And I have got a case study, but I don't know if we have time for that. I don't know if Madeleine is still on, or Stephanie, if you're going to take over.
Yeah, we've only got about 10 minutes left, so there are a couple of questions.
Right. Okay. So let's stop there. Let's stop there. Let's allow for that.
Okay. Thanks, Julie. I mean, that was an amazing presentation. So the first question is, thank you for the excellent presentation. Would like to know whether a patient who has a positive urine LAM result are positive for pulmonary or extrapulmonary TB.
Good question. That would usually be pulmonary, but it would also depend on the patient, right? So if the patient has come in with clinical symptoms of pulmonary TB, then it would be considered pulmonary. So I think just the important thing, maybe I didn't clarify, that it doesn't matter where the TB is. If it's actively multiplying, it's creating this protein. So if it's creating the protein, it's going to get into the patient's blood system. And if you've got leaky glomeruli, it's going to get into the urine. So it doesn't really matter where the TB is. So deciding on if it's pulmonary or extrapulmonary would depend on what symptoms and features your patient has got.
Okay, and then the other question is, what is the role of ESR in assisting the diagnosis of TB? Should we still be doing it?
Yeah, it's one of those really sort of peripheral things. I mean, an ESR it can go up quite a lot in TB, but it can go up in almost anything, and especially in kids. I mean, kids are little walking disease monsters, right? They get everything. So I don't think an ESR of 120 would necessarily help me to decide if this child has got bacterial pneumonia versus TB. If I'm trying to and I mean, a child who's got severe acute malnutrition, and you're trying to decide, listen, is this all just malnutrition or is it TB? I mean, that child's probably got all sorts of fungal infections and all kinds of things that could push it up. So, we do sort of include that as a sort of side test, but I don't think that would be enough to put a nail in the coffin. And it's the same with monocytes. So I mean, we do pick up that monocytosis is a bit more common in children with TB. That would maybe be sort of slightly added support, but I don't think that alone would be enough. I think the one message really to get across here is that there is no perfect test for TB in kids. It's really about putting the whole puzzle together. And sure, maybe ESR is a very tiny little puzzle piece, and high monocytes a very small piece, but it's not going to name it for you. I can't see if there are any more questions.
I don't know if there are any more questions, or people could raise a hand if they have a question. I don't see any raised hands. And okay, here's one. Is it recommended to start TB treatment empirically while waiting for bacteriological confirmation? And if you did and later culture is negative, can you interrupt the treatment?
Okay, good question. And absolutely you would, if you've got enough other evidence. Remember, the lab is not really as helpful in peds TB as they are in adult TB. So you usually have to start empirically. And if it comes back negative, remember, only 10 to 50% of kids who do have TB will have a positive result. So I would certainly not stop the TB treatment just because the lab test comes back negative. It's helpful if it's positive, because then it can tell me if I've got drug susceptible or drug resistant TB. But a negative, I mean, most of the kids I've looked after have had negative TB cultures. So once you've made that decision, you continue with the treatment.
And then somebody is asking if it's possible to share the slides.
Yes, I did share it with Stephanie. So you're all welcome to have that. Also, one thing I didn't add is we've got quite a few support groups, peds TB support groups. I think we've got 8 for different provinces. So I didn't add the slides here. We've got QR codes. I'm sure many people on here. I'm happy to share them with Stephanie if you'd like to join some of those. Unfortunately, because of the USAID cuts, it's a bit ambiguous on what the real role of those groups would be, but I think that there are so many clinicians, particularly in the Eastern Cape, who add to that. So I think it belongs to the province effectively, but that's a really good way. If you've got a patient and you're not 100% sure, you don't know if these look like lymph nodes on the chest x-ray, or you're just not quite sure if this counts as significant contact, or you're having a problem with some of the medications, that's a really good way to share your question. I still try to participate as much as I can on those, but that's a very nice learning platform. And I always encourage people to ask questions there, because every question that gets raised, everyone learns from. So I'm happy to share that with Stephanie as well, if that's helpful.
Thanks. There are no new questions up. Oh no, yes, there is. Okay, a stool sample, is it acceptable in our labs at District Hospital, and what do we request?
So a nice question that is in the memo that was shared on the Rudasa form, and I'm sure that memo will start to be circulated a little bit more widely. The lab currently has 18 laboratories that are going to be doing the stool testing, but they, it's not available everywhere yet. Just remember that that stool sample is going to perform even worse than your pulmonary sample. So it's not a lifesaver. It's a very soft, maybe it will work. What you fill in on the forms is you request a night test, and you have to fill in that it's a stool sample. Even though you'd think it's obvious, sometimes if it's a very runny sample, the lab doesn't know what they're dealing with, and you have to put the age of the child on the form, because if the form doesn't give the age, they only accept children under 10, so they will reject your sample if it's not stated. And also think carefully how to get those stool samples. I've written a long story on how to actually collect the samples, but if it's a Friday afternoon and it's going to take 2 days to get to the lab, it might be better in some situations to try and get that stool sample for the mom to collect it at home and get it through on a weekday, depending on how far you are from your lab. So according to the NICD, they were hoping to go live on the 1st of April, but for the moment, I would strongly recommend that you just phone your lab and ask them if they're ready to receive your stool sample. But in reality, you would probably have made your decision even before you send that stool sample on if this is a child who needs TB treatment or not. That's just an added bonus to the diagnostics.
Okay, thanks, Julia. We've literally got a couple of minutes. I am going to see if I can share. If you could stop sharing, Julia, I just need to share a slide. Okay, that's just to let everybody know that although this is the last in the onboarding series, next week we start the first of our monthly webinars. It will be on allergies, specifically on chronic urticaria. And the monthly webinars are going to be on the first Wednesday of each month. So it's this day at 6 o'clock. And there's 8 of them. So we're really pleased this year that we've managed to get 8. And you can see it's quite a good selection. We'll be doing something on SAMS, something on wound assessment and dressings, something on neurology, possibly stroke. We're still waiting for them to tell us. The causes of maternal deaths, particularly looking at medical and cardiac disorders, practical approaches to palliative care in the emergency settings. And then we're going to do rabies and snake bites. So we hope that you will also continue to join the webinars every month. And Julie, just thanks again for the presentation. It was